Welcome, James Leckie, to the interview. I'm really excited to have you. We've been talking about this for a long time over Twitter DMs, but you're a healthcare policy expert, and I'm really glad to have you on the show. So, do you want to give our listeners a quick introduction about yourself, what you're working on, and plug your social media and whatever other projects you're working on right now?
Yeah, thanks for having me. So, like you said, my name's James Leckie. So I have just been on Twitter a lot, but I have a blog. It's American Healthcare Wonkery. I'm a health policy analyst by trade. I work on different management consulting contracts, primarily focused on Medicare. But outside of work, I just do a lot of self-directed research. And I'm just very interested in how we can get to universal healthcare and make our system work a little bit better.
Okay, cool. And in that vein, you had an excellent blog post come out today where you basically went step by step of the kind of history of American healthcare. And I snuck in a couple of peaks during the workday, got through it bit by bit, and it was an excellent article. And I'll make sure to link it when I post the podcast. But for people who are first time listeners, could you go through the history of American healthcare, just like from inception to the kind of I don't want to say mess. I don't want to, belittle my American listeners, but to the kind of conundrum that it's in right now.
Yeah, no, it is a mess, but yeah. So I guess you could point out that like during the Civil War and things like that, there were, doctors where people would just use their houses and they'd saw off limbs and things like that. But a lot of the professionalization of it started about 100 years ago in the 1920s. After World War I, Congress consolidates several different bureaus and creates the Veterans Bureau. It later becomes the VA, and that helps create a system of essentially socialized medicine for veterans, where they have hospitals that are publicly owned hospitals. They're on salaried pay for doctors, everything like that. And soldiers or people returning from war can get the care they need, and their families to some degree. But outside of that, it was basically the Wild West for a long time. It wasn't well regulated. People could just hang a sign on their door and say they're a doctor. And so during the Progressive era, there was a professionalization of the industry where people started going to college, they started going to medical school, hospitals that had primarily been charity care and were pretty primitive compared to what we do today. There were mostly places that people went to die. It's pretty depressing. And so this starts to get created in the 1920s, this system. And one of the big things, you're a social democrat, progressives are arguing for things like pensions, workman's comp, unemployment insurance. Mm-hmm. And one of those big things is sickness insurance, health insurance. Now, in the 1920s, a group of teachers works with Baylor Hospital, and they basically create hospital insurance. Back in the day, you didn't just have medical insurance and that covered everything. It was very specific to specific industries. You had hospital insurance, surgical insurance, dental vision, medical, all that stuff. Around the same time, a few years later, doctors realize what's going on, and so they decide they want to get involved. That Baylor Hospital project became Blue Cross. Doctors get involved with their own nonprofit insurance scheme for medical insurance for visiting a doctor, and that becomes Blue Shield. So the Great Recession hits, and the progressives who've really been out of power for the last 12 years come into it with FDR. And he picks as his labor secretary, Frances Perkins, who is an activist and social worker, and she worked in the government, and she's a true believer in a lot of this stuff. So a few years into FDR's administration, they start working on the Social Security Act, and they're going to try to tackle everything. They're going to try to create a pension system, unemployment insurance, workman's comp, everything. But there's a huge problem in that there's these collection of different groups that are all, for their own reasons, opposed to national health insurance. You have the hospitals and the doctors who are against it, basically because it could cut into their bottom line. You have the Chamber of Commerce. They're against it because they don't like the taxes. Social conservatives are against big government. The GOP is very aligned with the social conservatives of the time. And then you have unions, who a lot of people are surprised by that, but the American Federation of Labor in the US was fairly conservative, and they also thought that all these benefits like minimum wages and everything like that, that should be up to what the union can fight for you. And it should be specific to your workplace. Otherwise, what's the point in having a union? So all these groups work together and unite in opposition, and they decide, we got to lose this national health insurance thing. This isn't going to pass. So they just take that trade, decide it's not worth it, and just let it be. Social Security Act passes, and that's a transformational change. It's great, but health insurance falls by the wayside. So a few more years pass, and World War II starts, and the government just starts deficit spending like crazy. Because of this, they, for several reasons, are worried about inflation. So they create the Stabilization Act. It sets a bunch of price controls on huge swaths of the economy. It even caps people's pay and how much you can really give people raises year by year. But employers, being pretty intelligent, figure out, okay, well, they capped our wages, but if we give them benefits, then that's not really the same thing. And we can go ahead and offer people really sweet deals, and unions are kind of down with it because they realize this is great bargaining power that we can use over the same time. So the FDR administration basically gives a wink and a nod and said, you know, like you guys say, like this isn't really part of the act. And, you know, in fact, it's not even really income. So the IRS can't even really tax it. So they just let it go. And this goes on for about 10 years. But in the meantime, FDR is pretty old and unhealthy. He dies. Truman gets elected, or he takes over. And he decides he's going to run his own version of the New Deal, the Fair Deal. And one of the things he wants to do is create national health insurance, part of the New Deal that basically got cut out. But by this time, the more conservative Democrats had been against it for a long time, and they've been pushing back against the Roosevelt administration for years. So when they have a less popular president, they are very fine with having this fight, and they align with the GOP and say, we're not going to do this for all the same reasons. You have unions, social conservatives, everything like that. And again, a lot of Democrats in this era are from the South, and they're segregationists. And they're really worried that if you have a national health insurance plan, that Truman will desegregate the hospitals. So it's just America's problems with race coming to the forefront again. It dies, and he crashes and burns so hard that the GOP flips Congress for a couple of years. And by 1952, he's incredibly unpopular. Eisenhower's elected, and the GOP says, now is our chance. Like, we can dismantle the New Deal. This is going to be great. And Senator Taft is one of those staunch conservatives. But Eisenhower makes the call that, you know, like, guys, we really shouldn't do this. Let's just legitimize the employer system and just move along. Like, we will allow this to continue. I don't think people really wanted this when they elected me. So they make the employer-sponsored health insurance model permanent. It's just a regular part of the tax code. And we're basically stuck with that system today. And so the idea is that if you have a really good union job, you can get great health care. If you're retired, you might not be able to get that. If you don't have a union, and in a lot of cases, that's people that are disproportionately poor, if you're a kid or if you're a spouse of someone and your spouse dies, you probably don't have health care. So by the end of the Eisenhower administration, the uninsured rate's down to probably about 33%. 1 in 3 people don't have health insurance. But a lot of the progressive activists realized, like, okay, we can see why this failed. we tried to help everyone. So how about instead, we just try to get coverage to the elderly? That's all we want to do. It'll be a national federal plan. We'll take care of the elderly in their final years. That seems pretty reasonable. JFK gets elected, Democrats have a very strong majority, but JFK is not that good at working with Congress, so nothing happens until LBJ takes over when JFK is assassinated. And LBJ is much more effective at working with Congress. So he passes this plan. The AMA argues instead you should have a voluntary plan instead that's private. LBJ and the Democrats decide, no, like we're not going to do that. Like we're just going to have this plan. And there was an earlier grant system. It's like a federal state matching program. Like you guys have that a lot in Canada, I think too, where they wanted to help out the poor elderly who were what they called indigent. And that was the Kerr-Mills Act of 1960. So when they created Medicare, it was separated out into hospital insurance and medical insurance. And that's why they have those two parts for Medicare Part A and B. And that covered all the elderly people. But for everyone else, they decided, okay, well, how about we just take the design of the Kerr-Mills Act and use it for other people that might be, needing some help. So it was primarily aimed at the disabled, mothers, children, the poor elderly, to help them out even further. And they basically kicked the problem down to the states and said, okay, like this is this system. Like we'll pay for half of it or more than half of it. You guys figure it out. And like this is no longer a problem. And that's how they got it past a party that still had a lot of Southern Democrats. They just said, okay, like we'll kick the problem of like who we're going to decide is deserving down to you guys, and you'll figure it out, and we'll all sing Kumbaya. It passes. For some of those conservatives, they felt tricked and wanted to repeal it pretty quickly. But LBJ basically pulls a fast one and says, no, not going to do that. And we have that system today. And with Medicare, it goes out within a single year because it's an earlier system. And like they were worried about with national health insurance, they said, well, if you do this, they'll desegregate the hospitals. LBJ, being a politician he is, says, okay, well, we passed the Civil Rights Act a year ago. And guess what? If you want all this money, and you do, because most of the people that come to you are elderly, you have to desegregate your hospitals. And that's why hospitals are desegregated. He basically just jerry-rigged it and used the money to force them to take it. And that's also why everyone takes Medicare, is because the elderly were the vast majority of the market. And it's not viable for hospitals to have a system where they say, oh, well, we're not going to take elderly patients, because they would never make the revenue to stay open. So you have Medicare, you have Medicaid, you have employer insurance. The uninsured rate's probably about 15% at this point. They're a whole lot closer, but they're not there yet. LBJ is pretty unpopular by 1968 for various reasons. Nixon wins, and he has to work with the Democratic Congress. So he can't go full conservative. He has to work with Democrats a little bit. At some point, they decide that people with like end-stage kidney disease can get Medicare, even though they aren't elderly, because it's just non-viable. They make other small changes. They even start talking to Nixon about a universal healthcare plan. Nixon comes out with his plan. Ted Kennedy and the Democrats come out with their plan. Ted Kennedy's plan is more like a single payer plan, like Medicare for all, just like Truman and Medicare had. But Watergate becomes a huge scandal. And so basically the Democrats decide, like, we can hold out for something better. It's all going to work out in the end. And it doesn't work out. Turns out Ford, he's more of a conservative. He's just not interested. And then Jimmy Carter, after Ford, still not that interested and not that good at working with Congress. And then in 1980, Reagan's elected. And Reagan was going on tours and taking out radio ads for the American Medical Association, talking about how if they pass Medicare, that America is going to live in a world where they talk to their kids about a time where they used to be free. So he's not a fan. But Democrats still control the House, and he has to work with them. So they make these piecemeal little changes. One big thing that does happen is medical inflation has been like going crazy, even with Medicare for years. So they create like a diagnosis code system to fix that. They raise the Medicaid rate for mothers and children to 133% of the poverty line. That'll come back later. And do other things like add hospice care, make it so you can't literally bleed out in front of the hospital, just like really low level humanitarian things. And 12 years go by, nothing's happened in major ways. And Bill Clinton gets elected, and he's a new Democrat, right? He's not in favor of single payer, but he's really for universal health care. So instead of doing a single payer plan like Ted Kennedy wanted or Jesse Jackson wanted, he says, here's what we're going to do. We're going to create employer mandates. We're going to create an individual mandate. We're going to control costs through healthcare alliances, and everybody's going to get covered. But basically, you have the same group of people come in, or the same interest groups that come in and say, we're not for this. This is going to cut our pay. You're going to have government-run healthcare, and it's going to be awful, even though it's like relatively private. They try for over a year to get this done, and it crashes out right before the midterms. And because of that, or in part, they lose Congress for 14 years. It's going to be stalled again for another about 20 years or so. And basically, Clinton is forced to just deal with Republicans for the remainder of his presidency. They make some fixes to the employer system where you can't just tell people that they're not going to get covered based on health status or something like that. They create CHIP for kids, and that's similar to Medicaid. And it's in that it's a block grant to top off more childcare, because the child uninsured rate was still like 15%. That's pretty bad. And so they picked that whole deservedness mindset again and said, okay, well, like you can all agree that kids shouldn't be uninsured. And you get people like Orrin Hatch to say that, that makes sense, while the Republican majority leader staunchly against it, but it's still able to pass anyway. And so all of these states get block grant money to decide on their own how much they want to expand health insurance for kids. And they create Medicare Advantage, sweeten the deal somewhat. So there's a privatized version of Medicare now, and some other stuff. George W. Bush gets elected. He takes that voluntary AMA model to create a marketplace for drug insurance, pharmaceuticals for Medicare. That passes in 2003 and gets launched by 2006. He starts stuffing incentives into Medicare Advantage so that it grows quite a bit faster. And by this point, we're pretty close to the system we have today. But one big problem, the self-employed system, the marketplace outside of getting employer insurance or any government plan, still a nightmare. You have lifetime limits. You can get kicked off your insurance for having cancer or fairly minor other pre-existing conditions. They really go into trying to figure out what your health status is to see how much it costs. So Obama gets elected. They try to enact the ACA, and his plan is basically the Clinton plan, except for the fact that they decide not to try to control costs. They decided what they learned was they bit off more than they could chew, and they allowed all of these groups to form an alliance to beat them once again, just like they'd been beating them for the past 70 years. And there you go. So the AMA and the American Hospital Association decide that, this is acceptable for us if we can still make money. They put an employer insurance firewall for the marketplace so that unions can say like, oh, well, we're not going to leak these plans. They have an employer mandate. And here we are today. And they do a Medicaid expansion, of course. And the Supreme Court makes it voluntary, but because of the design of the subsidies, there are people that are stuck in a gap, and people that if they make too much money or sent too much, then it's just completely on their own buck, And so that did again It was the biggest decrease since Medicare and Medicaid's creation. And now we're kind of just stuck in place right now with about 8% of the population uninsured, partially just from undocumented immigrants, but in large part because people that are qualified, about half the people that are uninsured qualify for aid, whether Medicaid or Obamacare. But it's really kludgy and you have to pick a plan. It's really hard. That's just where we are today. It's better, but not where we need it to be.
Yeah, I mean, from the article and your breakdown of it right now, it just seems like it's not really like a coherent system. It's just like a bunch of systems patched together into one to create this kind of pseudo working, healthcare insurance industry. Was really cool, and I think the funniest part I really liked about your article, I don't know if I'm misstating this, but it was about doctors, not considering like optometrists and dentists as real doctors, and that was outside the insurance coverage, which is funny because it echoes true here too, because our Medicare only covers about 70% of costs. Optometry, prescription medicine, and dentistry is not covered for some reason, even though I'm going to have my teeth for the rest of my life, so I don't understand why it's not covered. But yeah, anyway, thank you for an excellent breakdown. So moving on from that, and I think in a similar context, the U.S. basically has nothing, but a bunch of public-private partnerships. And you wanted to talk a little bit about how it's a great example of like a highly concentrated market with hospitals and insurers. Do you want to expand on that a little bit?
Yeah, sure. I'll try to make this one a little bit shorter.
Oh, take your time.
Yeah, so a lot of people think Medicaid, Medicare, public, Obamacare, and off-market employer insurance private, right? That's not quite right. If you look at Medicare today, about half of people, or close to half, have privatized Medicare Advantage plans, where they basically just pay a private insurance company that can be for-profit to do the same thing that someone would get, or something similar to traditional Medicare. They kind of make it easier to get dental, vision, and hearing coverage on Medicare Advantage than traditional Medicare, so it's a little bit biased. Or they might want an out-of-pocket max. So half people on Medicare, it's actually private. The supplemental market on Medicare, also private, also can be for-profit. So it doesn't really work either. Medicaid, again, people think, oh, this is public insurance. 75% or about 75% of Medicaid are managed care organizations, private for-profit companies, Blue Cross Blue Shield, Aetna, United Healthcare, everything like that. So what the government basically does is just hand these companies a per person chunk of money and just says, get coverage for these people. And then Obamacare, you think, well, that's private, but it's heavily subsidized. Some people, like right now, with ARPA subsidies, if you make less than 150% of poverty, you don't have to pay premiums for a silver plan. And in fact, you can get much lower deductibles and things like that. So it's not perfectly private if it's extremely subsidized and heavily regulated. And same thing with employer insurance. Not taxing something is the same thing as a subsidy to some degree. And having all these regulations to change it, but that's really not the same thing as fully private. So we don't really do purely free market fundamentalism. We don't really do public insurance. We just have a collection of private public partnerships.
You're just like the zombified monster of like different just packed together things. And I think I was pulling up a couple of articles, and these are things that I've read. I think two things is I think you've written before about like underinsurance. Could you go over a little bit of that, about what did like how many people are underinsured right now? And also a second thing is that these kind of complex plans overwhelm the people choosing them. Because I remember this article that says, complex Medicare Advantage choices overwhelm seniors because, people aren't really the best at judging what kind of health insurance that they need. So do you mind talking about those two a little bit?
Yeah. So, I mean, in terms of underinsurance, just because you can afford your premiums doesn't mean that the insurance you get is good enough that you can afford your care, right? Like if you make $20,000 a year and you don't have premiums, that doesn't mean that your doctor's visit's going to be affordable. Those copays are still real. And one of the things that they tried to do with the ACA was they really bought into Switzerland's model, where they said, well, we can control costs and bend the cost curve by making people feel this. So what we're going to do is we're going to have deductibles, we're going to have co-pays, we're going to have co-insurance. We'll put an out-of-pocket max on it so that you won't be any worse. But that out-of-pocket max is like $8,000 or something. That's a lot. So yeah, so it really is like, it's more like catastrophic coverage to some degree. And so there's different definitions of how you do uninsurance, but basically you have this good and it's subsidizing your coverage and it gives you a fail safe, but that doesn't mean you're going to be able to go to the doctor and afford it. Maybe you'll forgo things in your grocery bill that you otherwise would take. That's not great. And what was the other part of your question?
The other part was how this kind of, we were talking about Medicare Advantage, but there's been papers on this that say that when there's these like complex choices of underinsurance, of insurance, people tend to not choose the optimal kind of insurance that they need. Like how much do you see this as a problem?
Yeah, I mean, to some degree, it's a big problem, right? I mean, are you going to be able to perfectly know how healthy you're going to be in the next year, right? That's part of what insurance is. It's supposed to be about helping smooth out those income shocks, right? Or those shocks to your expenses. But if you're pretty healthy, you might think, like, oh, I don't actually need that much. This is going to be fine. But then you get diagnosed with cancer or you get appendicitis, and that will still financially break you. Because those out-of-pocket maxes are so high. And I mean, aside from that, when most people are buying their healthcare, a lot of people, when they're buying their healthcare, they just think about what their premiums look like. They don't pay quite as much mind to, well, what's my out-of-pocket maximum? What's my deductible look like? What's my co-insurance look like? What are the networks like, right? So it's just so complicated that for a lot of people, it's almost impossible for them to make the perfect decision. Yeah, it's a huge problem.
And I mean, sorry, I cut you off.
No, go ahead. And just, there's dozens of plans to choose from. People might not necessarily understand the difference between out-of-pocket max versus a deductible or co-pay versus co-insurance. There's a lot of moving parts to this.
Yeah, and I think it's with Medicare Advantage, it seems to be for, elderly people who, at the tail end of life, you're lower in your kind of cognitive decision making, and these are people who would have a harder time choosing insurance than you would like somebody who's in the labor market, an adult and of sound mind. So it's kind of nuts. And also, I remember this. I can't recall what study is that people are just like really the kind of view of the free market health insurance types is that, okay, like people should be able to go around and shop for the health insurance. They should be able to shop for their doctor, whatever. But I remember reading the study that said, like, on the way to like getting an MRI, people pass through like 6 lower priced MRI scans. Like people, I don't even know, are optimally fit to do that kind of decision making on a, like a healthcare market. So it's absolutely insane to me that we want to kind of just leave it up to the free market.
Yeah, and I mean, people care about choice a whole hell of a lot, but there's such a thing as too much choice. And when you have to select between dozens of different plans, and for a lot of places with the ACA, it is dozens of plans, it's incredibly hard to make a decision based on that. And you don't necessarily know which doctors are going to be covered. If you get your doctor covered, that's your primary care physician, maybe the lab isn't covered, and then you'll get a surprise bill, or maybe the surgeon isn't covered, or the tech isn't covered, or the hospital isn't covered, or there's different fees. It's a nightmare, but we love to give people lots of choices.
Yeah, I mean, but as you said before, it's kind of like the illusion of a choice, because you have these copays, you have these deductibles, you have the network that you're in. So you're not really getting a choice in the actual consumption of healthcare. You're getting a choice in the consumption of insurance, which seems to me to be two different things.
They're totally different. Yeah.
Yeah.
You really just don't know what you're going to get with that plan. You just know what your insurance is going to look like.
And I think this is one question I wanted to ask you, and this is something that's I read Medlock has tweeted about is that in terms of just in terms of pure finance, the goal of insurance is basically to price risk, right? But we've decided as of the ACA that discriminating based on your healthcare status is a no-go, it's unethical, whatever. So what do you see as like the role of private insurance right now? Because they can't really even price risk anymore, right?
They can price it based on age and smoking status, right? So
Mm-hmm.
if you are a really honest person and decide to tell them that you smoke cigarettes, you can do that and you might get a 50%,
Mm-hmm.
price increase on your premiums, or you just lie and you get cheaper health
Mm-hmm.
insurance, right?
Mm-hmm.
And then there's age, which, the elderly need health insurance more than young people.
Mm-hmm.
So I think with some estimates, some people think the elderly pay or use about 6 times as much healthcare as a young person. But in the ACA, they subsidized it somewhat, so they're only allowed to charge the elderly 3 times
Mm-hmm.
what a young person pays, right? So
Mm-hmm.
they are selecting on that, and it gets more complicated where they do have like a risk adjustment where they figure out which insurers are selecting the healthier patients and the sicker patients, and they force them to transfer between each other.
Mm-hmm.
Um, so yeah, it really is. It's closer. It was like a half step towards private markets in European models like Germany, where they say
Mm-hmm.
you guys are really just an intermediary. For them, they're forced to be nonprofit. Here, we allow them to be for profit,
Mm-hmm.
and just say you guys are just intermediaries. You're not even going to worry about the figuring out prices and stuff. We'll handle it. In America, we take a half step approach to that. But because we love choice and we love competition, we decide to let insurance companies negotiate on everyone's behalf.
Mm-hmm.
And that's part of how you get network issues where someone could be in network or out of network, right?
Mm-hmm.
So if the insurance company doesn't like how much a certain hospital or certain doctor is charging, they can just say like, well, we're not going to cover you. That does lower your premiums on that plan, but there's a trade-off where it can be harder to navigate the healthcare system.
Mm-hmm. Fair enough. So I guess we've talked till now a little, basically about how crappy the system is, how it's a patchwork of a lot of different things. But let's talk a little bit about like what you envision. Like, how would you fix a system? How do you move towards public insurance? And also, what would a public insurance system for America look like? Because there's such a like panoply of options. There's like I've heard about universal catastrophic coverage. I've heard about single payer. Or you have like totally nationalized, like the NHS model. Like, what is your optimal model? How do we get there? And what are the moves that we should take from here?
Yeah, I'm not sure about an optimal model. I think theoretically, single payer is a good idea.
Mm-hmm.
I think you might have concerns about how well are we going to fund single payer, considering that Republicans that are adamantly opposed to it are in control of the federal government about half the time. But in principle, I think it's solid. I know some people like Ed Dolan from Niskanen talks about universal catastrophic coverage. I think that's worth looking at least from a start. I mean, one of the nice things about Canada is you guys
Great
basically
country.
you basically just solved the problem where you just said like, like everybody gets hospital insurance, right? And like everyone gets some form of medical insurance. If you want more, you can buy private insurance, like go for it, but nobody's getting left out. The default choice is you have coverage. We don't do that here. I think any form of doing that would be better. One version you might be able to do in the US relatively soon would be something like Maryland does for the cost side of things, where they have this thing called all payer, which is what Germany does in global budgeting, where number one, all insurances, whether it's public or private, pay the same price for the same good at the same hospital.
Mm-hmm.
So theoretically, there's no real reason for an insurance company to not put a certain hospital in their network.
Mm-hmm.
And to some degree, you might be able to control costs. Now, when you look at the ACA, their unsubsidized premiums in Maryland are among the lowest in the country, partly because they do that. And even though Maryland is like one of the richest states, they're pretty cheap when it comes to American healthcare. That's relative, but
Mm-hmm.
it's better. So controlling costs That would be good. Universal coverage, catastrophic coverage might be good. Something else you might be able to do is really increase funding for Medicaid substantially so that there's enough money that in a pinch, if someone has to go to the ER and get an emergency surgery, Medicaid will cover that bill for you. And if you really should have had insurance, like if you're, someone who makes like $100,000 a year or something like that, and you didn't do it, maybe they could do something like they do in like Japan or Germany, where they say like, we'll cover this bill, like don't worry about it, but we're going to enroll you in a plan, and come tax time, the premiums that you owe us that we decided is fair, you have to pay us back, and like it's going to be for the whole year. And that's another way you might be able to do it in the short term. But we haven't done it yet.
So what you're saying is that there's already kind of encouraging like systems within America that you could probably pursue on at least a national scale, right? Like a Maryland type model.
Yeah. Yeah, you could do Maryland. Vermont does something similar. Rural Pennsylvania does too. Actually, a lot of states used to try to do it in some form or another, but they moved away from it in the 1980s and 90s. And they started rolling it back and saying like, we'll just do narrow networks and we will hand off Medicaid money to the private sector, because the private sector is better than the government at cutting costs. And turns out that's not quite true for Medicaid, but like, so we've done it before. To some degree, a lot of countries and at different points, different parts of the US have figured out how to do it again.
And so one of the reasons I do like talking about Canadian healthcare is that there's like a stark difference between how our kind of public healthcare system works versus the parts that are not covered by that system work. People are generally happy with, our national kind of insurance model. There's a whole lot of pride that we have for it. But on the other side, like, for example, like the prescription drug coverage that's completely left up to private insurance is like a total mess. Like, I think 7.5 million Canadians are underinsured for prescription medicine. I think 3 million Canadians every year are unable to afford like one or more of their prescription drugs. So you just kind of see this private market failing in like really pivotal areas. So it's always made me awestruck to see how much people kind of want to retain this private insurance system in the US. Just looking at how much of an abject mess it is. And so this brings you back to what we were talking a little bit earlier about, was the copays, deductibles. How do you make a pitch to the average American about why the superiorities of adopting like maybe a national like single payer healthcare scheme?
Yeah, I mean, I think one thing you could say, I know a lot of people have, like, some people really like the idea that it's free at point of service, and you could say it's free healthcare. Other people really, for whatever reason, resent that. They think that some people are getting something for nothing or something like that. I think this is really hard. I don't think anyone's really figured that out, and I think that's why we are where we are. Maybe you could say something like Bernie has tried to say, where it's like, hey, like, we're just paying for it through taxes. We're just making sure everyone gets covered. We just want to make it a little bit simpler for you, so that you can just pick your doctor wherever you want it, and you won't have to worry about this whole network issue. And you won't have to worry about paying these premiums every month, because we've already decided that for you. It's just like getting, the child tax credit or the EITC or the money that comes out of your check for Social Security when you retire. Like, we're just making it easier for you. And I mean, with seniors, we do this with Medicare, where like there are Medicare premiums for Part B, but it gets taken out of their Social Security check automatically. Like, I'm on employer insurance, it's taken out of my paycheck automatically. Like, we're just switching that from the employer paying it to the government paying it. It's not that different fundamentally. It's just making sure no one gets left behind.
And I mean, just a quick question. I don't know if you have the data on this, but what is, like, how satisfied are the people that do have Medicare and Medicaid? Like, are they satisfied with that kind of insurance model that the government's providing?
I'm unsure about Medicaid. I know Medicare, like, people are pretty satisfied, relatively. somewhere in like the upper 80s in terms of people that are generally satisfied. I mean,
Mhm.
nobody likes paying premiums, and if you don't make a lot of money, that could really hurt. And I mean, that's why there is a market for $0 premium Medicare Advantage plans, right?
Mhm.
Um, with Medicaid, I think, you know, it is very helpful.
Mhm.
It's leaps and bounds better than not having coverage.
Mhm.
There are real quality concerns there are quality concerns sometimes that you do have to worry about, and that's part of the entire stratified healthcare system, right? Like if you have a good employer insurance plan, you can get really great healthcare. If you get Medicaid, the reimbursement rates are very low, so you have to figure not every doctor is going to take that money, and it's going to be harder for you to find an in-network doctor if you have Medicaid.
Mhm.
And of course, there's stigma of taking Medicaid because
Mhm.
we just love talking down to poor people for whatever
Yeah.
reason. So most Medicaid plans like don't even have Medicaid in the name because they're just so worried about that stigma.
Mhm.
Um, Medicare, people are pretty satisfied for the most part. There's problems, but
Mhm.
it's okay. Um, that's also true of the ACA, interestingly enough. Like
Mhm.
people that take it, um, upper 80s of people that are generally satisfied.
Mhm.
Um, but you know, I'm satisfied with my employer plan. It could be a whole lot better, you
Mhm.
know,
Mhm.
like just because it's kind of like approval ratings for a president, right? Like just because
Mhm.
you generally think someone's doing an okay job
Mhm.
doesn't mean that you don't think it could be a whole hell of a lot better.
Mhm. Absolutely. That's basically all the questions that I had for you. But one question that we do ask everybody that we interview is basically if you had to take kind of one pivotal aspect of what's, let's call it James Leckie thought, and kind of put that into the minds of every American, like what would it be? What is like the one thing that underpins basically the kind of way that you approach this healthcare issue or
I would
life in
just
general?
I mean, I would just say take yes for an answer. Don't be Ted Kennedy in the 1970s saying no to a universal health care plan because it's not the ideal plan. Don't say no to expanding Medicaid further or expanding CHIP or something like that just because there are going to be problems. Nobody has figured this system out perfectly. Any system that you are going to create is going to have flaws. Make it better. Make it as try to get as much progress in as you can at any one point in time, but get to yes and help a lot of people's lives.
Mhm.
You know,
I like it.
doing this over decades makes sense
We
sometimes.
we love some pragmatism on this channel and on this podcast. Anyway, thank you so much, James, for taking the time to do this. I've been wanting to do this for a long time. I have a very pedestrian understanding of American healthcare. So thank you for illuminating me and everybody else listening on this very complex issue. We really appreciate it.
Thanks for having me.